Well, good evening in the US and good day around the world. Thanks for joining us on our AO North America webinar on both bone forearm fractures. I want to acknowledge the chair of the Hand Education Committee, Marco Rizzo, for helping put this together. I'm Jeff Lawton. I'm the moderator. And as this topic is one that is useful for hand surgeons, general orthopedists, and trauma surgeons, my presenters represent such. So Jamo An is my friend and partner at the University of Michigan, an orthopedic traumatologist. And Nikki Zielinski is an orthopedic hand surgeon and director of the brachial plexus clinic at Emory University in Atlanta. So our disclosures have been mitigated and addressed in terms of content validation. Remember that AO is an independent nonprofit surgical subspecialty dedicated to education. We're not talking about how to use a specific product, plate, screws, etc. in this talk. We are talking about using equipment, but the goal is education, not how to use a specific product. So in general, as this audience knows, both bone forearm fractures certainly have a profound impact upon our patient's upper extremity, affecting the elbow, forearm, and wrist. This webinar will highlight and discuss the articular and skeletal anatomy, treatment options, and I sort of broke it up a little differently, as you'll see, in that we're organized by level. We want to sort of focus on the less routine and the more challenging, as you will see, and then we'll talk about rehab and how different cases impact the rehab. Specifically, I've asked the faculty, and you'll see, to focus on some tougher cases, those distal cases where fixation, especially in the ulna, can be hard to come by, proximal cases where fixation both in the radius and ulna can be a challenge, and then I'll tackle the dorsal or Thompson approach, as it seems to be the least utilized and something that some people don't have much experience with. Again, at the end of this session, you'll be able to identify the skeletal and articular anatomy as it relates to these fractures, recognize the mechanism, involvement, impact upon the wrist, forearm, and elbow, identify indications and various options for operative treatment for each of these components, and then have a familiarity with the rehab protocols. I do want to bring a couple other courses, regional hand and wrist course in Jersey with John Capo, and then our advanced upper extremity, the comprehensive trauma and flap course in Cincinnati. Other webinar activity in December, a distal radius malunion webinar, and then a few online sessions with these noted sages, Chai Mudgall, who was our former Hand Education Committee chair, Harry Hoyen, similar chair, and then Jesse Jupiter and Lee Osterman. So just a little bit of Zoom etiquette. The microphones have been muted and your cameras have been turned off, but that doesn't mean we don't want to hear from you. We certainly do. Please send any questions in the Q&A. And the three of us will answer some of them directly to you, depending on what it is, and depending on time, we may pose them and answer them on the air. And then we'll use the chat. So we'll ask you to use the QA. So this is an overview. Start with an intro and a case discussion. And then Nikki Zielinski will talk about distal both bone forearm fractures. Jamo will talk about proximal both bone forearm fractures. And then I'll talk about the dorsal or Thompson approach. So this first case is a young lady, isolated injury, who fell on her left arm while ice skating and presents with these films. And as you can see here, she's got this both bone forearm fracture. And then as I look at these, I always want to think about what do I want to address, the radius first or the ulna first? But since I'm talking about a Thompson approach, you may ask yourself, why is Thompson approach relevant to this, as it's sort of a mid-distal third fracture, as you see here. But if you look closely, and it's a little difficult to tell, you can see that this is actually a segmental radius fracture. So we'll talk about that. I am going to stop sharing, and then Nikki Zielinski is going to present on distal both bone forearm fractures.
I'm working on it here. All right. Great. Sorry. Okay, so I'm going to talk about times when the fractures are so distal that you might need something other than just a standard 3-5 plate. Actually do have a disclosure, which is that I'm a paid consultant for TriMed. And these are my objectives for y'all at the end of this session. I'm hoping you'll be able to preoperatively identify fractures that might need non-traditional fixation and plan fixation with alternative strategies. But most importantly, probably is know where plates can and can't go in these distal fractures, specifically distal ulna fractures. But let's start with the radius. This is a 34-year-old who status posed multiple gunshot wounds, including to the radial shaft. You can see a moderately comminuted radial shaft fracture. And the first thing I ask myself when I am consulted for an injury like this, other than are they neurovascularly intact, is what kind of plate am I going to use? Am I going to use a standard 3.5 LC-DC plate, or do I need to use a specific plate that is formed to the distal aspect of the radius, like a metadiaphyseal plate? And I came up with this rule for myself early in practice, and I'll show you how I came up with it, which is that if the fracture is greater than 6.5 centimeters from the joint, it's probably okay. You can use a 3.5 plate. And this is how I came up with that. My goal is always to get 6 cortices of fixation in these both bone fractures so I can mobilize them as quickly as possible. So I measured on a 3.5 plate, how much of the plate do I need sitting on flat bone to get 6 cortices using a bicortical screw, and that's about 4.5 centimeters. And then I measured a bunch of distal radius x-rays, and I found that that distal flare of the metaphysis is about 2 centimeters on average, give or take a little bit. And so if you add these two together to get this 3.5 plate laying flat on the diaphysis of the radius, you need about 6.5 centimeters of room from the radiocarpal joint, which is easily measured on an x-ray. So for example, on this patient where the fracture extends to within 5 centimeters of the joint, if you tried to place that plate, you could see that the screws would be in the fracture, and that does not abide by AO principles. So my plan here would be to use a plate that's more specific for the distal aspect of the radius. When planning for this case, I think it's important in these comminuted fractures to get x-rays of the contralateral wrist. Ideally, you get these before you get into the operating room, but you can shoot these with your mini C-arm in a stitch if you haven't gotten contralateral x-rays. But it is really important when you're shooting wrist x-rays to calculate the variance, the radial ulnar variance of the wrist, to know how to do that. These have to be done with the shoulder abducted to 90, the elbow bent to 90, and the thumb pointing at the shoulder. Otherwise, as you supinate your forearm, the ulna looks relatively short compared to the radius. And as you pronate your forearm, the ulna looks relatively long. So when you're shooting the contralateral film or when you're checking the variance on a comminuted fracture, you have to make sure that the wrist is positioned in neutral. So you have to start with that. So this is just an example of how I put this plate on. So I typically will pin the plate to the shaft to get my plate balance approximately. And then I put the screws in the oblong holes. And this lets me really fine tune the proximal distal placement of the plate. And then of course, the plate is simply secured to bone. Typically I'm using non-locking screws in the shaft and locking screws distally. These patients, in my practice, in a simple fracture, relatively simple fracture like this, are made platform weight bearing. He is able to weight bear for ADLs, and he does not get a splint postoperatively. Here he is at 6 weeks. Unfortunately, he's still in the hospital, and we got these x-rays yesterday. I would say that he is healing, although not entirely healed, but he's using his arm to weight bear as he rehabs for his other lower extremity injuries. And these are specific wrist x-rays that we obtain as well, just to check his ulnar variance. So my indications for not using a 3.5 plate, for using something like a diametaphyseal plate, are typically extra-articular fractures. They have to be, they're usually less than 6.5 centimeters from the articular surface. You can make a simple intra-articular fracture, an extra-articular fracture, either with a clamp or interfragmentary fixation before you put this plate on. But if I'm doing that, I'm typically choosing something more like a long distal radius plate. All right, let's move on to the ulna. So I'm going to start this discussion with a case of my partner's. She's an 80-year-old that had a ground level fall, and you can see this relatively comminuted, angulated distal radius and ulna fracture that even after reduction is quite displaced. She elected for operative fixation of the radius. And my previous partner, Clifton Meal, said that fixing these distal ulna fractures in the older population is trying to put a plate and screw in a wet mop. It is very difficult and it is never satisfying. So she underwent spanning fixation of the radius with no fixation in the ulna. And she went on to heal this. These are her 10-month postoperative x-rays. But the proof is really in the pudding here, because what we're worried about with displacement of these distal ulna fractures is a loss of prosupination. So this is 2 months after her surgery. The plate came out at 1 month, and she has excellent prosupination and good wrist range of motion as well. So not all of these need to be fixed. There are a number of different classification schemes for distal ulna fractures that generally refer to the amount of comminution and the location of the fracture. But it's important to remember that these classifications are not predictive of outcome. So you don't have to fix all of these. Unfortunately, we don't know which ones you do need to fix and which ones you don't. But if you do decide to fix them, there's a whole cornucopia of options for fixation. And I'm going to talk about the 3 most common. Those are mini frac plating, a hook plate, or like a distal ulna specific plate, or K-wire fixation. Before we get into that, we definitely need to spend some time talking about where to put these plates on the distal ulna. So these plates can be placed on the ulnar border, the volar aspect of the distal ulna, or dorsal. And there's different structures at risk no matter where you go. Volarly, the ulnar neurovascular bundle is right there, and the articular surface of the distal ulna is closer than you think. On the ulnar subcutaneous border, when you get this distal, the dorsal sensory branch of the ulnar nerve is there, and dorsally the ECU, and the articular surface is again going to be in your way. So this is a structure that unfortunately I see commonly injured at outside hospitals in my nerve practice. It's a very sensitive nerve. The dorsal sensory branch of the ulnar nerve can pass anywhere from 0 to 4 centimeters proximal to the ulnar carpal joint. So in this picture here, you can see this is about where the distal ulna is, and this is that nerve crossing right over the head of the ulna. But this can be as far from the ulnar carpal joint as 4 centimeters. So if you are in the distal third of the ulna, you absolutely have to find this and protect it. Just be very wary of it, because this nerve does not take a joke. Volarly, it seems like you have a lot of real estate on the volar distal ulna to put a plate. But once you remove the capsular attachments, you can see that the articular surface of the distal ulna actually encompasses 270 degrees of the articular surface. So it is a large portion of the distal ulna when you're getting into the distal sigmoid notch that is going to articulate with that radius and could impinge. Dorsally, the ECU, you have to be mindful of the ECU as well. So this is looking at the back of a right hand. This is the radial aspect, and this is the ulnar aspect. This is where the ECU runs in the 6th extensor compartment. And if you move the retinaculum, you can really see how much the ECU moves with ranging from pronation to supination. So you have to be very careful that your plate is not impinging on the ECU as well. So my gosh, with all of these structures in this area, where are we going to put our plate? Well, thankfully, Dr. Bindra studied this for us. He did a very nice anatomic study where they looked at a bunch of cadavers, and they removed all of the soft tissue, and they pro and supinated the wrist and the radius around the ulna, and they marked where the distal radius and ulna touch each other. So they found the safe zone for us. So much like we have a safe zone in the proximal radius, there's also a safe zone in the distal in the distal ulna, and where you can put a plate without it impinging. And that safe zone is about 2 centimeters wide, and it's immediately volar to the ECU tendon. All right, so let's get into a case here. So this is a patient of mine. He's 57. He's got a bunch of open fractures, including this type 2 open peri-implant both bone forearm fracture. And I started with the radius. Although there was an implant in there, I did think it was the more simple of the fractures. I did a bunch of interfrag fixation, and then I just placed a very long 3-5 plate.
Roberto Hernandez.
And then I'm left with this distal ulna fracture. I tried to make it as simple as I could with a lag screw. You can still see that there is this radial sided butterfly fragment, but this is relatively one big piece. And I fixed it with this plate.
Roberto Hernandez.
So this is the this is a tarsometatarsal fusion plate. So it's not a plate that's meant to sit in the distal ulna, but I really like it in this area. It's a 2-7 plate. And although it's a little bit stiffer than a 2-7 adaptation plate, it is certainly not as stiff as an LCDC plate. It has variable angle locking capabilities distally. And so it was really good for this area as long as it's used appropriately. So this particular patient, I was a little bit worried about my fixation. I think probably in hindsight, I could have moved that plate more distal in order to get better fixation of the distal ulna. And now, of course, looking in hindsight, that plate looks really small compared to that zone of comminution. I did protect him in a sugar tong. So usually my both bones, I don't immobilize, but he went in a sugar tong for 6 weeks. I did allow him to play platform weight bear as well because he had some lower extremity fractures. He came back at 6 weeks. He had minimal pain. He had good wrist flexion extension. He was neurovascularly intact. That plate, I did through a volar approach. It goes very proximal. So the PIM was something I was very much being mindful of, but I slowed this guy down. I kept him. I tried to put him in a cast, but he did not want that. So we put him in a removable orthoplast. Unfortunately, he came back at 3 months as expected with that very small plate and the large zone of comminution. That plate broke. He was pain-free at the time. He had relatively good prosupination. He was very happy. I was not happy. He came back at 4.5 months. He had abundant healing after that plate broke, and he actually did very well. I think probably a better option for him would have been something like this, where I did a 90-90 plate construct in order to have a little bit more security on that distal ulna. So my tip that I learned from this case is don't let technology triumph over technique. There are a bunch of plates that are meant to go on the distal ulna. They're all relatively small, and even that TMT plate was not strong enough for my guy. So here's another case where I learned quite a bit. So he's a 32-year-old. He's right-handed, and he came in with an open distal both bone that you can see here. This is his post-reduction film, and I couldn't really tell where the ulnar head was. So we got a CT. And you can see that that ulnar head is sitting behind the radius. It's completely dislocated from the DRUJ, and it was blocking the radius reduction, closed reduction. So if we could open the poll, I'm going to keep these images up here, and hopefully you guys can take a look at this. And I just want to hear what everybody else would do from the potpourri, what the people in the audience would do. Would you do mini frag fixation? Would you leave the ulna alone once you got it reduced? Would you try a tension band, K-wires, or an intramedullary screw? We'll leave that up there for maybe 10 more seconds. And can we put up what the audience said? There we go. All right, most people would do mini frag fixation or K-wires. I love that. Nobody wants to do an IM screw. All right. So this is what I did. I initially tried to start with the radius. I actually approached the radius first after I washed out the open ulna, but I could not get that radius reduced with the ulna sitting in the back of the wrist. So I had to take the ulna out of the back of the wrist. It was unfortunately almost entirely devoid of soft tissue. While it was out, I placed this little suture anchor so I could fix the TFC. And I placed a lag screw and pinned things kind of in place provisionally. And then I used this little pin plate as a neutralization plate. Then I fixed the radius. I did a soft tissue repair of the TFC, and he was stable. You can see me, this is my little clamp holding everything. And you can see that his DRUJ is now reduced and he was stable. So I was relatively happy leaving this case. Unfortunately, he came back at 6 weeks post-op. He had a complete block to pronation. And on these lateral x-rays, it's very concerning to me that the ulna is subluxated dorsally. So we got a CT, and you can see that it's almost entirely dislocated dorsally. And here we go. We'll take a look at that 3D view just so you guys can see it's dislocated dorsally. So I spent a lot of time thinking, and let's open the next poll, what the problem was here. Was it a failure of my TFC repair? Was his DRUJ unstable and he was just subluxated dorsally? Was it a problem with the bone, or was it both? Admittedly, I initially thought that it was just a failure of my soft tissue fixation. He had extensive soft tissue stripping around the distal ulna fragment. Yeah, you guys are smarter than I was. I talked to some of my partners. We all looked at this together, and we came to the conclusion that it probably was at least the bone. So if I There we go. We've got whirling the CT around. You can see it's very subtle, but I fixed that distal ulna fracture a little bit dorsally angulated. And unfortunately, it's probably pushing the ulna out the back. So I had this guy prepared for 2 surgeries, one to revise his bone, and then potentially another surgery to do something like a Berger Adams, where I reconstructed his entire DRUJ. This is what I did to start. I took out all the hardware, and it was very unstable. Again, it was the entire DRUJ, and that's very small piece was very unstable. I started by pinning it to the radius. I was happy with my my reduction of this fragment to the radius, and then I just tried to fix it as best I could. I can tell it is obviously not well reduced here, but I thought it was good enough. I kept him in a Munster cast for 6 weeks. Then I gave him a removable Munster for another 6 weeks with OT that was directed at dart thrower's motion. So it wasn't flexion extension. It's not ulnar radial deviation. It's dart thrower's motion, as if you were throwing a dart, which unloads the DRUJ. And I'm going to show his clinical outcome before his x-ray. So here he is. I saw him a couple weeks ago. He's 3 months after the revision. He's got excellent prosupination. He's entirely pain-free, and he has good wrist range of motion. These are his x-rays from 3 months. So it's not sexy, but it does look like it's healing. I think there's a couple of osteons crossing that fracture. He has obvious signs of hardware loosening, but I think that he's healed enough that we're just leaving it alone, but we are watching him carefully. And I am letting him weight bear as tolerated at this point. He is living his life. This is my last case. So he is a 58-year-old status post being attacked by a dog. They have ulnar-sided soft tissue injury, and this was an open fracture. So the radius is pretty simple. I'm going to fix it with a diametaplate. What about the ulna? It was open over the ulna, but the soft tissue was closable and it was in pretty good condition. So could we do the last pull here? What would we do with this ulna? Same options: mini frag fixation, leave it alone because it's comminuted. It was open at one point. Would you try to do a tension band, K-wires, or an IM screw? All right, maybe we can close that and see what people would do. Mini frag fixation. I think that's reasonable. And then some fewer votes for K-wires or IM screw. So my partner fixed this. This is not a technique I do very often, but I think it works well when used in the right situations. The one thing you have to remember if you're doing any sort of K-wire fixation of the distal ulna is you still have to protect the sensory branch of the ulnar nerve. Even if you're making a small incision, sweep that soft tissue out of the way before you get your starting point. Otherwise, it can get entangled in your K-wires. I've seen issues from this where people get neuromas later. It's a mess. So he did a very nice job of getting that K-wire all the way down the ulnar shaft, directing it with a little mosquito. It looks very nice. And that patient went on to do well with it. Just a little bit of extra stability from this K-wire fixation. So my take-home messages are dimetaphyseal radius plates are useful if the fracture is less than 6.5 centimeters from the radiocarpal joint. The safe zone of the ulna is immediately volar to the ECU tendon. The proximal ulna is likely okay to put a plate anywhere as long as you're not at the level of the distal sigmoid notch, the DRUJ. And distal ulna fractures don't always warrant fixation.
All right. Excellent. Thanks, Nikki. And there was a comment that last case, someone mentioned doing a suave Kapanji, which would be an interesting treatment as well. So thanks, Nikki. And now we're going to move to the other side of the forearm. Jay Milan, who's an orthopedic traumatologist and the chief of our ortho trauma at University of Michigan, is going to talk about proximal both bone forearm fractures.
All right, I can promise you that I will definitely not teach you as much as what Dr. Zielinski just taught you, but perhaps I'll confuse you a little bit. And more importantly, I want to stimulate you so that hopefully we all start to understand more what we don't know and discuss with each other, especially the last case will, I think, leave many of us confused, including myself. So we're moving up to the proximal side. And just to begin by, I want you to consider these 3 x-rays. I'm going to give you a few seconds just to start gathering your thoughts on what you would do, what you're seeing. And I know we have varying levels of training and practice here. So I'm not going to go through the very, very basics, but just think of how you would approach this. And with that said, the overall feel here is we're going to go through a relatively quick series because I want us to be able to move on by 8:40 to discuss more of the Thompson approach, which will become relevant in some of my cases as well. Some principles going into practice, basics plus making you think, especially with the third case that I'll present. And please pretend you're with me. Say, oh there's no way I would have ever done that. Or, wow, that was so smart. That was brilliant. When I ask a question, I'm not going to do a poll so that we can keep moving along, but please answer for yourself. Would I replace it? What kind of plate would I use? Would I use a fancy pre-contour plate? Would I do something else? And so please follow along as if you're sitting right here in this room with me, discussing actively. So when going proximal, just a few things I hope to leave you with. They're very general, but I think they will help create sort of a structure by which you can think about these fractures. Remember the elbow. And what I mean by that is think about the stability of the elbow. Think about the PRUJ as you get closer, just like at the distal end, you have to rethink how you're going to fixate. You have to think about the soft tissue structures. You always have to keep the elbow in mind. The ulna is your base. The ulnar trochlear joint at the elbow is critical to the distally and the forearm. And making sure that you have length, make sure that you have the bow of the ulna. These are basics that I think that you all know, and I won't specifically reemphasize necessarily as we go through these cases, but just remember that the ulna is your base around which the radius will rotate. And so fundamentally, making sure that this is as best as you can make it is important. Stability over motion, what I really mean by that is, of course, motion is very important, but if you have too much motion, you may need to favor stability. There's always that kind of balance, but when it comes to the elbow, there is more motion that you can get at a later time, even though we're all stiff. We're all afraid of a stiff elbow, but if you don't have that stability and you end up with a floppy joint or a floppy forearm, then patients are never happy. Okay, so this case is in the context of a lot of things going on. Actually, both forearms are fractured. Plastics ended up fixing the other one. The left humerus also fractured, tibia, acetabulum, a lot of things going on in this particular patient. Okay, just let's be shown back in the right place here. And so think about what you would do to treat this. Here's a little bit more on the left showing you the kind of fracture the ulna is, relatively simple. You can see that at least in this view, the joint, the ulnar trochlear joint is relatively, appears to be stable. It appears that the PRUJ is probably stable and you have a very proximal radius fracture. Okay. So what are you going to do with that radial head? Will you fix it? Will you replace it? What are you going to repair? If you're going to fix it, think about the kind of plate that you're going to use. And Nikki brought up nicely your options between using a plate from another set, using a pre-contoured plate, utilizing a mini frac plate, utilizing a small frac plate. This is sort of part of the body where you might be using all of those different elements of fixation. What is your approach going to be and what's your order of business? These are things that we always think about when you have a both bone scenario, whether it's the midshaft, proximally, and distal. I'll go through a little bit of the sequence that I took, and I want you to keep thinking about, do you agree with it? Do you disagree with it? Would you have done something? So one of the principles that I brought up is that the ulna is going to be really important as a stable base around which the radius can rotate. And even though the actual motion of the radius is much more as you go distally. Having that foundation proximally is important. So I got the ulnar length, placed a mini frag plate. My preference has been small bones. I use small plates, even though I use a lot of large plates for larger bones. I tend to use smaller plates because I can get greater points of fixation. I'm really going for stability a little bit more than strength. If I need additional strength in addition to the stability that I get with small screw fixation, I will place the second plate, which can enhance both stability and strength. And then for the radius, after getting the reduction initially and doing K-wire fixation, the overall open approach that we took to get this reduced the way we wanted and plated. And Dr. Lawton will talk a little bit more about this in terms of the approach, but this is essentially naturally sort of asking for a Kaplan approach that naturally can extend into a Dorsal Thompson approach. And in this particular case, because it wasn't quite base of the radial neck, took a little bit more extensile approach so that I could place a mini fragment plate. Many of you may be using special plates, pre-contour plates that fit this anatomy better. I found that many of those, even the smallest ones, still feel pretty bulky in my hands. So I will often go down to a 2-4 plate or even occasionally gasp for an orthopedic trauma surgeon, a 2-0 plate when I need it. So here I take the elbow through a range of motion for stability, and there were a few fluoroscopic images that showed a little bit of gapping in the ulnotrochlear joint. The radial head appeared to be stable, the PRUJ appeared to be stable, and with a little bit of the ulnotrochlear instability, no soft tissue work was done. We encouraged afterwards active flexion of the elbow, which will also secondarily engage the triceps and allow for enhancement of joint stability rather than providing additional fixation or repair at that point. So this was our final construct. We did allow this patient, Nikki mentioned this with one of her cases, we did allow this patient to platform weight bear, and especially with all of these other injuries. So we're going to move on to the next case because I would like to get the opinions of our other two panelists once we get to the third one, because that one is still evolving, and I have a few different options for what to do next, but it would be really interesting to get our other panelists' input as well. Here's our second 47-year-old right-hand dominant woman, motor vehicle collision, and here are the x-rays that demonstrate a very proximal ulnar fracture, as well as you can see on that oblique lateral, a injury not only to the radiocapitellar joint, but to the radial head. A little bit more resolution on these images. So please start thinking about what you would do, how you would fix it, will you replace it? What about the comminution in the ulna? Just like we saw comminution very distally in the ulna and the radius with Nikki's cases. Do you think this comminution proximally will be a problem? How will you address it? And anticipated approaches and fixation. Okay, fix, replace, repair approach, order of business. So in this case, because of the comminution of the ulna, and because the radius was simple, I use a technique that I also use in the next case, which is I reduce the radius and that establishes length. Because the radius is not a segmental injury, because part of the radial head is intact, once I reduce the radiocapitellar joint, that can establish the overall length that I need to also establish for the ulna, for both the ulna and the radius to act in concert. So in this case, I felt that the radial head piece was small enough, examined it, debrided like I typically do for small fragment fixation, got a good debridement right at the fracture site, placed the the piece back in, and fixated with two small mini frag screws. And then I went to the ulna, used a series of, I didn't quite Vinershka porcupine it, but I did use multiple clamps. At some point, I had even more clamps on, trying to hold that comminution that you saw in the CT in place. I felt that getting that comminution back into place, making sure I had as good of radial length as I could. All of these things would help establish proper relationship between the radius and the ulna, including the proper length. K wires put into position, and then started placing screws, as you can see. The one side took the clamps off, the comminution wasn't holding position, and even though getting that comminution in the right position wasn't necessary to maintain the length, I felt that in terms of the overall strength of the construct, we know that even though getting the comminution millimeter perfect may not necessarily affect overall healing, we do know that if you can get that into millimeter position, it does change the overall strength of your construct by quite a bit. So use a mini fragment plate. And of all the cases that I'm showing today, this pre-contoured proximal ulnar plate is the only one that I believe I'm using that's pre-contoured. That's the only fancy plate. Got that fixation as well. Tested the stability of of both the ulnar trochlear joint as well as posterolateral instability potentially of the radial head, and we found that it was actually stable. We had suture anchors on standby in case we would need to explore the LUCL and the lateral soft tissue structures, but it appeared to be stable in both supination, pronation, and with posterolateral force, so no additional soft tissue repair was performed. So please think about this and ask yourself, would you have done something differently? Would you have replaced the radial head? What kind of activity and motion are you going to allow afterwards? Will you splint this patient? It has just been the teaching that I've been given and the practice that I've had is I almost really never splint anybody unless I feel I really need to protect the soft tissues because of heavy trauma. If I have the fixation that I need, if I've performed the ligamentous repair that I need, I really don't know how to do the reconstructions. But if the repair is appropriate, then I prefer not to have them splinted, and I will only splint them for soft tissue protection. All right, let's go to the case that's really gonna hopefully get us thinking. This was at follow-up, patient's doing well. All right, so these images, both the clinical and the x-ray, came to me at about 1 o'clock in the, maybe midnight, sometime between midnight and 1 a.m. And I had one eye open and I'm looking at this thinking, what is going on? Do I have to go in for this? A little bit annoyed that I got an injury like this past midnight. And then I opened both eyes and looked at the x-ray a little bit more. And I thought, that radial head is totally in the wrong place and it's on the wrong side of the elbow. So then I really started getting worried and I activated the OR immediately and said, we have to go in and really see what's going on. So what now? Had to go to the OR. And this is what we found. It was really, this is of course not initially what we saw. This is after a debridement. It was a near amputation. Soft tissues badly damaged. You can see that even in terms of the bony structures, there are a lot of problems here, including of course at some point elbow stability. So then I had to do something to stabilize this. Before I actually went in and did the debridement, my initial thought, and maybe many of you had the same, was this should be X-fixed. And I thought about that. But I was able to, once I went back in, debrided everything. Again, I used the reduction of the radial head, and I got what I could in terms of length, trying to key in the pieces of the radius to a reasonable extent, had the radial head and the radiocapitellar joint in a reduced position, and then made an assessment of the ulna. That fragment was so unstable that I could not flex the proximal ulna enough to get a reduction. And so what I ended up doing was using the fracture site itself, sending a large K wire. I believe this was either a 2.8 or a 3, it may have been actually of a 3 millimeter, send it retrograde through the fracture, out of the ulna, out of the skin, excuse me, and then antegrade so that I can hold the appropriate position of the ulna. Now, the elbow joint itself is still super unstable overall because there's complete ligamentous disruption, 360 as well as the capsule. In fact, during our debridement, we could see some dangerous arterial pulsations, not bleeding, but pulsating, something that a trauma surgeon really never wants to see and wants to leave for our hand colleagues. So additional pinning across the joint for stabilization. And I made a decision to not do an X-fix, but instead pin across this joint, something that I learned many years ago from Daphne Beingessner, who first opened my eyes to when things are really bad, pinning across the joint is very reasonable and can lead to some initial grade stability. So you can see one of the pins sticking out. We were able to get a reasonable soft tissue closure despite the overall traumatic internal injury. So this was our X-ray and CT scan afterwards, the radiocapitellar joint in reasonable position. Length was maintained because the radiocapitellar joint was reduced and the ulnotrochlear joint in a reasonable position. The median nerve was completely out, so our hand surgeon did do a nerve grafting with the elbow still pinned. And what's next is where I'd like to get our panelists coming in at least for a couple minutes before we go back to Dr. Lawton. And this is where we are now. You can see one of the pins is starting to bend a little bit. Patient's coming back to see me this next week, and we're going to make our next plan. And I have some initial thoughts, but it would be great actually to get Dr. Lawton and Zelensky to chime in at this point and share with us some of their thoughts.
That's a great case, JMO. So you know, as you've said, you've got it sort of temporized, and you know, in this case, nerve repair, sometimes vascular repair, sometimes coverage. Obviously, you know, reconstructing that ulna with one of those fancy para-articular plates that you are loath to use, but I think that might be where I would go. And you know, bone grafting that sort of gap, segmental gap there. I mean, an X-fix I think is great. An X-fix probably wouldn't hold that radiocapitellar joint reduced, so I think you know, an X-fix might protect your sort of silver arrow, your Steinman pin there, but you know, letting the soft tissue mature is probably where I would go. Nikki?
I have more questions than answers. Is his ulnohumeral joint stable, like LUCL? No.
Everything is circumferentially completely out. The capsule, both medial and lateral ligamentous structures.
Yeah. So I think, I mean, obviously you have to like put that in the equation, because no matter what you do, those are going to probably need to be reconstructed. Even a stiff elbow with no ligaments is not good. So I would put that in your equation somewhere. I think you could do, I probably would do this ulnar bone gap with like a mascale. So you might do the ligament reconstruction at whatever stage of your mascale makes sense to you. And then is his tricep still attached to his proximal ulna?
Very attached. Yeah. At the initial debridement, it was so attached and pulling without any counterforce that I had a hard, was almost impossible, at least with my hands, I couldn't flex the elbow. I had to use a sharp instrument.
Yeah, so well, that's good then, and I think that might be at least part of your decision point on whether you're even going to keep that piece of proximal bone. We do well, not me, but my elbow partners do a bunch of APC proximal ulnas for destroyed elbows. But I think you have a good articular surface, you have an intact triceps. I think you can probably reconstruct this by reconstructing the ligaments and then doing, I would like a mascale or something for that bone gap. I would
Yeah.
back this up with either a hinged X-fix, an IJS, something so you have some extra stability, I think, on top of your ligamentous fixation.
Yeah, I did think about an IJS. My plan A at this point was to go in and take, at least initially, take out the pin going across the radiocapitellar joint, demonstrating that it is indeed unstable, which I think it will be. Putting in a fresh pin back in because it's going to be so unstable, and then basically do an elbow spanning plate, tricep splitting, distal humerus screws, have a plate going across the joint over the ulna, putting in a spacer for plan mascale, and then with my elbow partner, plan a ligamentous reconstruction. So that leave that in place, make sure it's not infected, go back, ligament reconstruction, and at that same visit, bone graft the mascale, because it's been 6 weeks and there's no sign of any kind of healing at all in that segment. But I apologize, I took a little too much time. Dr. Lawton, back to you.
All right. Well, great case, JMO. So now we're going to talk about the often discussed but rarely employed dorsal or Thompson approach. So my objectives are to familiarize you with this approach, endorse it in the use of proximal third radius fractures, gain some knowledge of the anatomical considerations of this, and it ties in a little bit with JMO's talk with proximal radius fixation. And then show you some examples and consider it for other fracture patterns and soft tissue injuries. So, you know, when we talk about forearm fractures, sometimes the approach is done for us, but usually we're doing various approaches. So the ulna, the traditional ECU, FCU approach, although as Dr. Zielinski pointed out, sometimes we're going volar, sometimes we're going dorsal. The radius most commonly utilized is the volar or modified Henry approach. Again, we're going to focus on the dorsal or Thompson approach. So again, Nikki sort of brought up the concept of, you know, where do I think I can get my fixation? So I sort of overlaid this proximal radius fracture, and this is sort of where a traditional small frag compression plate would go. And as you can see, you know, maybe you get about 1 to 2 cortices, I'm sorry, 1 to 2 bicortical screws, but then you can't get more proximal because of the bicipital tuberosity. So we're limited at this fracture with a volar approach, whereas if we go dorsal, as you can see, you can go all the way up to the radial neck. And sometimes you'll have segmental fractures and you'll overlap a small frag plate with a little condylar plate like JMO showed. So again, just to familiarize us with the Thompson approach, starts off making a line all the way from lateral epicondyle to Lister's tubercle. The muscular dissection superficially is the ECRB and the EDC. And then it's sort of, we talk about it often for the proximal aspect of the radius, but remember, this is an extensile approach, and you can use it distally. So just a word about the distal part of the Thompson approach. Remember the outcroppers, the first dorsal compartment muscles are there, and you can go subperiosteally, and you can go from proximal to distal and from distal to proximal, you know, with a freer or a small joker elevator, get your plate under it, Ragnell muscles one way, get your screws in, Ragnell the muscles the other way, and get your screws in if you want to go distal. Again, mostly we're talking about this approach going proximally. Proximally, obviously, the 900-pound gorilla in the room is the posterior interosseous nerve that I choose to identify it. Many surgical textbooks talk about, depending on your position, either pronating or supinating the arm and, quote, moving the nerve out of the way. Again, I'll show you why I like to identify it when I'm in this area. When you're identifying it, it's easiest to identify distally as it's coming out between the two heads of the supinator and work proximally. You can do this little peekaboo approach within the belly of the supinator, as you see here. And again, some texts will say just release the supinator and supinate the forearm. Remember, the posterior osseous nerve is very close to where you want to be. So here you see this small frag plate butting up against the posterior osseous nerve, as you see here. So the course of the posterior osseous nerve comes across the lateral elbow. Superficial radial nerve then comes off, and then finally the posterior interosseous nerve, or the motor branch. So it takes this sort of path through the supinator, as you see here. And I'll show you why this 4 centimeters is important. So in those cases that JMO showed with the proximal little mini frag condylar plates, sometimes foot plates, sometimes hand plates, little T plates, it turns out that this proximal part of the radius, you don't have to worry about the posterior osseous nerve, but around 4 centimeters you do. Again, there's a number of textbooks that say just pronate the arm or just supinate the arm and it moves it out of the way. But even in those textbooks, they point out that 25% of patients lack that deep head of the supinator, and the posterior osseous nerve is directly on the periosteum of the proximal radius and it doesn't move. We actually did a dissection study, an anatomic study in 24 cadavers, where we looked at how the posterior interosseous nerve moved with pronation, supination, and it turns out the average was about 1 centimeter of motion. But unfortunately, when you look at all those cases, there was a lot of variance. So really the difference in the excursion of that nerve from full pronation to full supination was minimal and basically statistical error, meaning you can't rely on that nerve to move like the textbooks say. As a result, again, in my mind, I think of if I'm 4 centimeters away, like I'm going to put a 2 or 3 hole small proximal radius plate on, then I think moving the supinator and the posterior osseous nerve out of the way is fine. But if I'm going to go beyond that, like that one condylar longer plate that JMO showed, I would want to identify the posterior osseous nerve. And again, here's a case sort of like JMO showed. So radiocapitellar joint is here. Here's a little T mini frag plate. Here's the posterior osseous nerve here. This is a segmental fracture. So here you see a small frag plate on that further diaphysis. And again, sort of working on both sides of the posterior osseous nerve, sliding your plate, getting fixation on both sides of it might be what you need for fixation. So we'll go through a couple cases. So this is a middle-aged person. This is a little bit more straightforward than some of JMO's cases. Again, at this level in the proximal ulna, you could either do a more traditional compression plate or a anatomically designed proximal ulnar plate. And again, in the proximal third of the radius, I think of the dorsal or the Thompson approach. So just working through the fluoropics, localizing my fractures. Here you see the ulna fracture, the radius fracture. And then similar to what JMO showed, getting my provisional fixation. As you can see here, fixation on one side, fixation on the other side of that ulna, getting my ulna out to length. It's a relatively simple pattern, so I went with that one first. And then putting in and getting my 6 cortices, as Nikki said. And then onto the radius, or where I was going to go for the dorsal Thompson approach. Again, in this case, using the Bovie cord, going from the lateral epicondyle to Lister's tubercle, as you see here. This was an open injury, so I just sort of made a little zigzag at his open injury. Here you see the superficial dissection, the ECRB and the EDC. And then here you see the deeper dissection, the free ears pointing to the posterior osseous nerve, as you see here. Here's the radial shaft here under it. And again, mobilizing the posterior osseous nerve and working on both sides of it. Here you see our fixation. So again, bicortical screws 3 above and 3 below the radius fracture, as you see here. And then Nikki had mentioned her rehab, and obviously it depends on the patient's overall condition. But you know, I do splint them for a week, but then I like to get them moving in a removable splint, range of motion up until about 3 months. And usually we are strengthening before we get radiographic evidence of healing, as long as your construct is stable. In this case, this person was a polytrauma, so I actually got 8 cortices above and below because I knew I was going to let him weight bear a little bit sooner. And here he is at 6 weeks, and then here he is at 3.5 months, nicely healed. So another case, this is an isolated injury, young, healthy guy who dumped his mountain bike. And again, he's got this ulna fracture and this proximal radius fracture. So sort of like JMO said, put yourself in this situation. Which bone do I want to address first? What are my approaches? And then, what do you ask for? What do you have the OR get for you? So, certainly with this ulna fracture, a traditional compression plate is reasonable. On the radius, there's a couple of options. You can go with a traditional compression plate. Remember, the radius looks different depending on how you approach it. So in a typical supinated approach, like you're going to do a volar or a Henry approach, remember the radial bow is sort of like it looks on this x-ray. It's a bow. However, in the Thompson approach, if you're over here, remember the radius sort of bows up and out of the plane of the table. So there are some anatomic plates that actually take this into account. Here you see these gold plates have a bow that you would use for a volar or Henry approach. It's tough to tell, but these grayish bluish plates, you can sort of see the shadow here, actually bow up and out of the plane off the table here. And these are designed to use for the Thompson approach. So you don't need them, but sort of clever taking advantage of the anatomy. So here's that patient, again, traditional compression plate on the ulna and a proximal radial plate, as you see here, restoring his radial bow. And here he is at 4 to 5 months. Here you can see that the Thompson approach, the guy got back good range of motion, as you see here. And last case is a little bit of a different case. This was a sort of a repeat offender, sort of like Nikki showed in her series. This was a 42-year-old guy who rolled over his ATV. He had a previous left both bone forearm fracture 25 or 26 years ago, as you can see here. And he's got this fracture, distal third of the ulna and mid shaft of the radius with his hardware fractured, as you see here. So you may say, what is this case doing in a talk about a Thompson approach? Because this is a mid or even a distal both bone forearm fracture. But obviously, this is a little bit of a tougher case because of his prior ORIF and that broken plate. So like Nikki showed in her case, you could certainly go through and remove those old plates and then do an ORIF with longer fixation, in this case in the radius and the ulna. But remember, those plates have been there for 25 plus years when he was 15 or 16. And if any of you have taken care of little kids with plates left in, remember that little kids heal and incarcerate their plates. So my operative plan was actually to leave most of the hardware in place, just take out the broken segment. It turns out that even that small little piece here of that third tubular plate was so encased in bone, I had to use a mini C-arm to even find it and an osteotome to excavate it. So I didn't really want to take out, it sort of validated my decision to not take out all his plates, avoid chipping out 1 3/4 worth of 25-year-old plates. So I chose to plate the fractures and overlap his previous plates and use a dorsal or Thompson approach to the radius. So here's the ulna, as you see here, just sort of getting our level. There's the radius. So provisional fixation of the ulna. So this is proximal, so you can see it's going to nicely overlap his previous construct. This is a plate holding forceps. This is sort of my secret weapon with both bone forearm fractures. I love this device. It is different than what comes in the sets. What comes in the sets are these, which are Verbruge clamps. A plate holding forceps has a little bit of a different end. It has this little swivel, and I really like it in these cases. So I'll climb back out of the rabbit hole, but just a vote of confidence for that particular instrument that isn't on most sets. So again, sort of like JMO showed, getting our length. So now we have proximal and distal fixation on that plate, as you see here. And then sort of getting our inner frags. I position it using the C-arm and drill these live, so I make sure I'm capturing those fragments, as you see here. And this is our final construct with 3 bicortical screws above and below and 2 inner frags, again, interdigitating with that ulnar plate. And then going to the radius, similarly, you can see the plate distally. Here's my plate on proximally. I have a single point of fixation proximally, and there's the plate holding forceps distally. And then, as JMO showed with the clamps, holding that in place, getting our fixation, and then again, drilling it live to make sure I'm capturing those fragments for inner frags. And there's my final construct, as you see there. Nikki made a great point of this. I think this is worth repeating, though. So typically we do these on a hand table. And again, remember to get that view at the end of the radial ulnar variance, the shoulder abducted to 90 and the elbow flexed to 90. And here you see a typical clinical picture here, and here you see what you want to see. So this is that patient at 3 months. Here's his range of motion. You can see how the Thompson approach heals. It heals pretty nicely. Good range of motion. So, you know, what the take-home points in the discussion, think in your own practice about how far you want to stretch a volar or Henry approach, when to perform a dorsal or Thompson approach. I certainly encourage you to dissect out the posterior interosseous nerve and protect it versus sort of the traditional move the arm and hope it gets out of your way. And then again, an eye towards rehabilitation as you're doing your surgery. And now we'll just wrap up our case as we're doing well on time to close. So again, with a polytrauma, you need to think in terms of early weight bearing, in terms of platform weight bearing, and certainly this would be a good case for a platform walker or platform crutch in terms of allowing a patient to weight bear early, range of motion, and then often we're strengthening well before we get radiographic healing. So here's this patient 3 or 4 months out. Here she is at 4 months. Again, good range of motion. And then remember that these fractures involve the elbow, the forearm, and the wrist. So that should be part of your rehab. So I want to thank our panelists, Nikki and JMO. I want to let everyone know this webinar and all the webinars that AO does will be available on the YouTube channel. We're also being broadcast on Ortho TV, so thanks to our partners on Ortho TV. Again, in terms of in-person stuff coming up in Jersey City, New Jersey, John Capo is doing a regional hand and wrist course. And then our comprehensive advanced upper extremity trauma and flap course, which is a cadaver course in November in Cincinnati. Again, webinar on distal radius and other online education for you. And I certainly want to thank my colleagues. And as it turns out, we ended right on time. So excellent job. Thanks, Abby. Thanks, Mackenzie. Thanks, Nicole Zielinski and JMO on. And have a good night, everybody.
Thank you.